Okay, IV fluids from class lecture, chapter 17, Lewis textbook. Albumin is a large molecule and will not pass through the capillary membrane. When fluid filters through the capillary, the protein albumin remains behind. When the concentration of albumin increases, fluid begins to move back into the capillary wall by osmosis, and the pulling force of albumin in the intravascular space is called plasma colloid osmotic pressure. As long as the hydrostatic pressure exceeds the plasma colloid osmotic pressure, water and solutes leave the capillaries and enter the interstitial spaces. It is pushing it through. If the hydrostatic pressure falls below the plasma colloid osmotic pressure, water and solutes return to the capillaries. As long as these pressures remain constant, there is no problem with balance. Without colloid osmotic pressure, the fluid remains in the tissue, which causes edema and swelling. Crystalloids are solutions that contain small molecules and are able to pass through semi-permeable membranes. Colloid solutions contain high molecular weight proteins or starch, do not cross the capillary semi-permeable membrane, and remain in the intravascular space for several days. Colloid solutions are blood products and total parenteral nutrition solutions. The tissue fluids and plasma in the capillaries have hydrostatic and colloid osmotic pressure. Hydrostatic pressure forces fluid and solutes through the capillary walls. When the hydrostatic pressure inside the capillary is greater than the pressure in the surrounding interstitial space, fluids and solutes inside the capillary are forced out into the interstitial space. IV fluids and electrolyte therapy are necessary to treat many different fluid and electrolyte imbalances. Other patients need corrective or replacement therapy for losses that have already occurred. The amount and type of solution are determined by the daily normal maintenance requirements and by imbalances identified by lab results. Tonicity is osmotic pressure of fluid related to the concentration of electrolytes in fluid, and this is important when correcting water and solute imbalances. The fluids are classified as isotonic, hypotonic, and hypertonic. So a little bit more about isotonic. Administration of an isotonic solution expands only the extracellular fluid. There is no net loss or gain from the intercellular fluid. An isotonic solution is the ideal fluid replacement for a patient with extracellular fluid volume deficit. Now, normal saline is indicated in conjunction with blood transfusion and for restoring the loss of body fluids. Watch for fluid overload, check their potassium and sodium balance. Be careful with sodium in renal patients, because you don't want them on too much sodium chloride. Isotonic solutions contain the same amounts of sodium and chloride found in plasma. Lactated ringers is indicated for use in the choice of burn patients and in most cases dehydration. It is also recommended for supportive treatment of trauma. D5W is considered isotonic, but once the dextrose is metabolized, it becomes water, and water is hypotonic. Isotonic fluids go into the vascular space and stay there, and an isotonic solution goes where you put it. So if you put it in the vascular space, the volume is going to build up and it will make the blood pressure go back up. A hypotonic solution provides more water than electrolytes, diluting the extracellular fluid. Osmosis then produces a movement of water from the extracellular fluid to the intracellular fluid. After achieving osmotic equilibrium, the intracellular fluid and the extracellular fluid have the same osmolality and both compartments are expanded. Maintenance fluids are usually hypotonic, half normal saline, because normal daily losses are hypotonic. Additional electrolytes like KCl may be added to maintain normal levels. Because hypotonic solutions have the potential to cause cellular swelling, monitor the patient for any changes in mentation because this might mean cerebral edema. Hypotonic has a lower osmolality than normal plasma. The water is pulled out of the vessels into the cells, resulting in decreased vascular volume and increased cell water. Hypotonic IV fluids are used to prevent and treat cellular dehydration by providing free water to the cells. D5W is used for patients who are dehydrated, have hypernatremia, can be given with some medication administration, nutrition. Remember, although isotonic in the IV bag, it does have a hypotonic effect as the dextrose is quickly metabolized, leaving free water that shifts osmosis from vessels into the cells. Half normal saline and quarter saline These fluids provide free water to the cells as well as small amounts of sodium and chloride. D5 and 1/2 normal saline and D5 and 1/4 normal saline both are isotonic in the IV bag, but because of rapid dextrose metabolism, both have a degree of hypotonic effect. D5 and normal saline is also isotonic in the bag, but does provide free water and calories to cells. The dextrose is mixed with the normal saline and provides less free water and more extracellular water than D5 and 1/2 or D5 and 1/4. This is used in temporary treatment of circulatory insufficiency and shock caused by hypovolemia, burns, and acute adrenocortical insufficiency. Hypotonic fluids go into the vascular space for a little while and rehydrate, and this is good. And then it moves into the cell, and the cell burns the remainder of the cellular metabolism. Hypotonic fluids have the potential to cause sudden fluid shifts out of the blood vessels and into the cells, which can cause cardiovascular collapse from intravascular fluid depletion and increase intracranial pressure from fluid shifts into brain cells. This is hydrating fluid that do not bring the blood pressure up because they do not stay in the vascular space. If a patient is hypertensive, then you don't want normal saline because it would increase the pressure, but they need fluid to rehydrate. Then hypotonic solutions would work best. A hypertonic solution initially raises the osmolality of extracellular fluid and expands it. Also, the higher osmotic pressure draws water out of the cells into the extracellular fluid. It is useful in the treatment of hypovolemia and hyponatremia. Hypertonic solutions require frequent monitoring of blood pressure, lung sounds, and serum sodium levels because of the risk for intravascular fluid volume excess. Hypertonic solutions are used in repairing electrolyte and acid-base imbalances and also include total and partial parenteral nutrition solutions. Hypertonic fluids have higher osmolality than normal plasma, causing water to be pulled from the cells into the vessels, resulting in increased vascular volume and decreased cell water. Hypertonic solutions are used to treat very specific problems and are administered in carefully controlled, limited doses in order to avoid vascular volume overload and cell hydration. Maintaining vigilance when giving hypertonic saline solution because of their potential for causing intravascular fluid volume overload and pulmonary edema. Closely monitor the patient for circulatory overload. Don't give hypertonic solutions to patients with conditions causing cellular dehydration, like diabetic ketoacidosis, because this would cause a worse shrinking of the cell. Don't give hypertonic solutions to patients with impaired heart or kidney function, since they might not be able to handle the extra fluid. And hypertonic solutions can cause great damage to a vein as their tonicity increases. Any fluids with the tonicity exceeding 500 milliequivalents per liter must be given through a central venous access device. Nursing management is to avoid hypernatremia and vascular volume overload. Saline solutions replace extracellular fluids lost through causes of dehydration and to correct water overload. It is also used to dilute medications. Dextrose solutions greater than 5%, like D10 and D50, are considered hypertonic solutions. They are used on a limited basis to treat patients with hypoglycemia, and hypertonic dextrose solutions are given in controlled setting, like an IV push or an IV infusion pump. Osmolality is the number of osmoles per kilogram of water. Osmolarity is the number of osmoles per liter of solution. Normal serum osmolality is 275 to 295. Isotonic is the same osmolality as serum. Hypotonic would be a lower osmolality than serum, and hypertonic would be a higher osmolality than serum. The osmolality is a concentration of particles dissolved in a fluid. The osmolality of serum can help diagnose several medical conditions like dehydration, diabetes, and shock. Serum osmolality is the concentration of a solution. The greater its pulling power for water. Osmolarity is a direct measurement of the concentration of dissolved substances in urine like diabetes insipidus. Because body fluid solvent is water and 1 liter of water weighs 1 kilogram, their terms can be used interchangeably in discussing human fluid physiology. Isotonic solution has a sodium concentrate of 154 milliequivalents per liter, which is somewhat higher than plasma of 135 to 145 milliequivalents. So excessive administration of isotonic sodium chloride can result in elevated sodium and chloride levels. Normal saline is used to expand intravascular volume and replace extracellular fluid losses. Can also cause intravascular fluid overload and hyperchloremic acidosis. Normal saline contains no free water, calories, or other electrolytes, and is the only solution that can be used with blood and is also compatible with most medication. Normal saline is used for shock, resuscitation, fluid challenges, blood transfusions, hyponatremia, and diabetic ketoacidosis. Use and caution in patients with heart failure, edema, or hypernatremia. This can lead to fluid overload. Although D5W in water is considered an isotonic solution, the dextrose quickly metabolized results in hypotonic due to the free water. 1 liter of D5W provides 50 grams of dextrose, or 170 calories. Although this amount of dextrose is not enough to meet caloric requirement, it helps prevent ketosis associated with starvation. D5W provides the free water necessary for renal excretion of solutes and is used to replace water losses and to treat hypernatremia. It does not replace any electrolytes. It should not be used for resuscitation and used cautiously in renal and cardiac patients. D5.5 normal saline is hypertonic that provides free water in addition to sodium and chloride. It is used to replace fluid loss and as a maintenance solution. It does not replace daily loss of other electrolytes, so you need to add the potassium if they need it. Lactated Ringer solution contains sodium, potassium, chloride, calcium, and lactate in about the same concentration as those of the extracellular fluid. It does not contain magnesium. It is used to treat losses from burns in lower GI tract and contraindicated in the presence of hyperkalemia and lactic acidosis, because in these conditions the body has a decreased ability to convert lactate to bicarbonate. It does not contain any free water or calories and is used with dehydration, burns, GI tract fluid loss, acute blood loss, and hypovolemia. It does contain potassium and can cause hyperkalemia in renal patients. Patients with liver disease cannot metabolize the lactate, and the lactate is converted into bicarb by the liver. D10 is a hypertonic glucose solution. It provides free water but no electrolytes. D10 is the highest concentration of dextrose that can be administered through a peripheral line. You need a central line to infuse higher concentrations, especially for parenteral nutrition. Plasma expanders stay in the vascular space and increase the osmotic pressure. Plasma expanders include colloids, dextran, and hetastarch. Colloids are protein solutions such as plasma, albumin, and commercial plasma like plasminate. Albumin is available in 5% and 25% solutions. The 5% solution has an albumin concentration similar to plasma and results in plasma volume expansion equal to the volume infused. This makes the 5% concentration useful in treating hypovolemic patients. In contrast, 25% albumin solution is hypertonic and draws fluid from the interstitial space. Now, dextran is a complex synthetic sugar, and because dextran metabolizes slowly, it remains in the vascular system for a prolonged period, but not as long as the colloids. It pulls additional fluids into the intravascular space. Hetastarch, or Hespan, is a synthetic colloid that works similarly to dextran to expand plasma volume. If the patient has lost blood, whole blood or packed red blood cells are necessary. The packed red blood cells have the advantage of giving the patient primarily red blood cells, and the blood bank can use the plasma for blood components. Although packed red blood cells have a decreased plasma volume, they will increase the oncotic pressure and pull fluid into the intravascular space. The use of whole blood with its additional fluid volume may cause circulatory overload, particularly in patients who are susceptible to complications from excess circulating volume, like heart failure. To prevent symptoms of fluid volume excess, loop diuretics may need to be administered with the blood.